Okay, good. How you doing there? I need to show you some stuff, okay? Okay, I'm gonna make you co-host, okay? Okay, did you accept that? for some reason, it's not letting me. Well, it's not letting me make you co-host. I don't know what's going on. Well, don't worry about it. Yeah, there's an option for me to let you be the host. In other words,
Okay.
you can let people in the panel. I don't know if you've ever done that before. I'm trying to.
Not yet. Not yet.
Okay, I'm trying to make you host. I don't know what's going on. Okay, there you go. You should get the option of being the co-host.
Yeah, I can see it.
Okay, now accept it. Now you should be able to let people in the panel. Because when people come in the panel, they're not really in the Zoom. They're just in the
Okay.
waiting room. You know what I mean?
Yeah, okay.
Yeah, but right now there's few people here. People tend to come late, and later and later and later. So, but keep an eye on that. If people want to come in, they usually put their hand up.
Okay.
Have you seen that before?
Oh, I don't see it.
Yeah, you don't. Yeah, you'll see it. It's a yellow handle. That means the person is in the waiting room. They want to come in the panel, you know, so they can talk like you are. They can interact. They can have a picture up there. If they're not in the
Okay.
if they're not in the panel with us, they're in the waiting room where they can see and they can hear, but we can't see their picture, and they can. Oh, good. How short is you got to meet this guy's good. Harshad, good
Hi,
morning.
good morning. Good morning. How are you?
Good. Are you at the hospital?
No, today is Sunday evening at home.
Okay, I'd like you to meet Ramadhan Kamela from Tanzania. He's a medical student. He'll tell you about himself. This is
Hi,
Harshad
Ahmad.
Parekh, one of our regulars here at the webcast of China.
Hi, Ahmad. How are
Hi.
you?
Hi, how are you?
Good. Where are
He's,
you
he,
based?
Yeah. Yes.
where you? Go ahead. Go
Where are you
ahead.
from?
Yeah, I'm from Tanzania. A
Okay,
medical student, fourth year medical student. So I'll be with Dr. John. We're going to I'm a co-host actually, so I'm going to moderate this event today. Yes.
great. Wonderful.
So how you been, Harshad?
I'm good, John. All okay.
Well,
How are
you know
you?
what, we came upon a good possibility because I does that mentoring on every other Friday in Tanzania. That's a good way to put it.
Yeah.
He basically mentors on a topic, and they show some surgery, and he wings it in the zone, but. That's a good thing to call it, mentoring. You have a senior neurosurgeon come into a country in Africa and mentor on a topic.
Great.
So anyways, maybe we'll have you do some mentoring sessions.
Sure.
So yeah, people seem to be coming later and later, but that's okay. That's okay. We're doing a few more webcasts in China, Ashad, trying to get into the Chinese neurosurgery community that
Correct.
speak English, because there's more neurosurgeons in China that speak English in the rest of the world. There's more numerically.
Mhm.
So we've got to try to exploit that audience of English-speaking Chinese. So we're going to try to, because they have the best website for videos in neurosurgery. I don't know if you've ever seen it. There's a couple, I'll write them down here. These
Mhm.
two websites. They are so much better than any that the Western Society has.
Okay, great.
Yeah, both those
It will be
websites
nice.
have a tremendous archive of videos, which they're in Chinese, obviously, but it's just a matter of time before AA starts eating them up. Oh, Akashi's here. Everything's going to be all right. Good morning, Takashi.
Good evening. Good evening. Now I'm working at the hospital, but it's okay. So
Okay.
this time, yes,
Yes, a
I'm
nice
available
a
now.
nice background.
Thank you, the Vancouver, but I transferred to the neurosurgical TV backgrounds. Okay.
Okay, whatever you want to do. But you could put a banner on that image. You can put a
Yeah,
banner on it.
the banner is
I love that background. I use it all the
yeah.
time.
This is the Kyoto,
Kyoto?
Kyoto temple,
What's the
temple,
name?
Kyoto,
That's the style is called Kyoto.
Kyoto. Yes, this is the Kinkakuji gold temple, Kinkakuji.
Oh, or is
Yeah.
that the only one? There's lots of them in Japan, right?
Yes, only one, only one. Kinkakuji is the only one. So, but this one, there are several historical villages, temples there. So,
Oh, there we go. There you go. Yeah.
hello.
Yeah, there you go. You got the banner on.
Yeah.
Yeah, let me show you a few banners I have here.
Hmm.
Let's see. You see that? Okay. There's Van Gogh. You see Van Gogh? There's the desert. That's pretty. Modern art. Okay. The speaker, Dr. Cow, is coming in, one of the speakers.
Can you hear me?
Hello, Dr. Cow. How are you?
Yeah.
Yeah, I'm fine, thank you.
I'm
That's good.
John. I'm John Bennett. I moderate and introduce either Dr. Ben or Dr. Lee. I'd like you to meet Takashi Kan. It is a neurosurgeon from Japan.
And thank you. Nice to meet you. I'm very willing to, excited to listen to your lecture, from Tokyo, Japan.
Okay, I'd like to meet Harshad. Are you there, Harshad? Perhaps he isn't. Oh,
Hi.
Shad, yeah, what
Hi,
you
hi.
need, Dr. Cow is giving the second presentation.
Hello, Dr.
Hello.
How are you?
I'm fine, thank you.
Hi,
Oh,
Takashi. How are you?
Hey, hey, I'm fine.
What time it is in Japan now?
In Japan, 9 p.m.
9 p.m. You are still working.
Yes, I'm still working at the hospital, so night shift. So, but no call, so I'm joining. I can join.
Wonderful, wonderful. Great to
Actually,
see you.
you're at a hospital now, right, Takashi?
Yeah, now I'm in hospital. I'm still in the hospital. Yeah, 2 weeks after I'll be in the same hospital and same working. So I'll be available next also.
Oh, okay. Uh, oh, Dr. Almeida, okay.
Okay.
Good morning, everyone.
Hey, good morning, Dr. Almeida.
Good
How are
morning.
you?
I'm good. I'm sorry, I'm just having some technical issues here. John, can I ask you a favor? I'm gonna send you my personal email, and I'm gonna ask you to please send me the information to log in because I'm trying from my computer so I can share the talk, and I'm having issues. I don't know why.
Okay, let me give you
I'm
my
sending you my
email.
personal email here in just a second.
Yeah.
Okay.
Oh, there you go. What do you want to do? You want me to?
If you can just send an email with the link, because
Yeah.
I've been trying here. I have my computer ready to go in front of me, but I just
Okay,
cannot access the link.
no problem.
Thank
No
you.
problem.
And good morning, everyone. And sorry for this.
Mhm. Okay. You want the link, right?
Mm-hmm. Or if you have the meeting ID number, because the meeting ID number that I have was not working as well.
Oh, okay.
Oh, I think I found a way here. I connected my. Yeah, perfect. Now you can see me.
Oh, it's okay?
Yeah, no, I fixed it. It's good.
Oh, okay.
Perfect.
Oh,
Okay,
okay.
good
So
morning, everyone.
so you jumped on your desktop.
I didn't know it could do this. It just, as I have both accounts on, it just gave me the option to switch to the computer.
Sometimes you can't figure out, it just happens. But okay, let's start, okay? Wanley, are you here?
Yes, I'm here.
Okay. Okay, do you want me to introduce Dr. Zhao, Dr. Almeida? Can you do it? Wanley?
Yeah. I can do it. Okay.
And Wanley is a neurosurgeon from Tianjin Hospital. Is head of the vascular department. Okay, we'll get started here. Let me see here. Okay. They changed the
Yeah.
interface on this.
That's okay. Yeah. So
Okay,
I
let
will.
me start,
Yeah.
Wanley, okay? Okay, 10,
Sure.
9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning. This is Dr. John Bennett broadcasting from Miami Beach, Florida, home of Neurosurgical TV. We have our bi-monthly Chinese Neurosurgical Journal webcast, and today featuring Zhao Almeida, Dr. Zhao Almeida, and I'll let Wanley introduce him. Good day, Wanley. Oh, I'm
Sure,
sorry.
thank you.
Let me say a few words about you, Wanli. Wanli's is a neurosurgeon at Tianjin
you.
Hospital. He's the head of the cerebral vascular department. Okay, Wanli.
Okay, thank you, John. Thank you. Good morning and good evening, everyone. This is Yuanli Zhao from Beijing, and I'm very glad to be here to hold this bi-weekly webinar for our Chinese Neurosurgical Journal. Today we have two speakers, and please allow me introduce the first one, Dr. Joe Amida from Mayo Clinic in Jacksonville, and Dr. Amida will talk about surgical anatomy and the techniques for resection of craniopharyngioma. Okay, Dr. Amida.
Thank you.
Uh,
Thank you very much,
please.
Dr. Yuan Lee, and
Thank you.
thank you very much, John, for the invitation. Pleasure to be here. Second time. First time I was in a trip in Las Vegas, actually, so that was interesting. And this time I'm home, so more organized. But sorry for the technical nuances we had before. It's a pleasure to join all the colleagues. I know that very robust audience from China, but I know also participations from Japan, India, and other sites in Asia. So my pleasure to be with you all today. So without further delays, let me start with sharing my slide here. And okay, perfect. So I'm gonna just go from the beginning. Okay, so I'm João Paulo Almeida, or JP Almeida. Everybody calls me JP around, and JP, it goes well. So feel free to do so as well. I'm one of the neurosurgeons at Mayo Clinic in Florida. I'm an assistant professor in neurosurgery with a practice focused on open and endoscopic skull-based surgery and brain tumors. So within that, last time that I was here, we talked about the cavernous sinus, and today we're going to be talking about craniopharyngiomas and about the suprasellar space, which is the most common site where we will encounter those tumors. Additional to that, we're going to be talking about some of the technical nuances that we feel it is interesting, and also we will discuss some updates in tumor biology that are important for the management of those tumors. I didn't have a chance to check, but I believe that I should have about 40 minutes, 30 minutes. Just checking with you guys. John, Dr. Yuan Lee, any suggestions about how long the talk should go?
Sure, 40 minutes would be fine, or longer if you needed.
Yeah,
I mean,
regularly about less than 1 hour should be fine. Thank you.
Okay, excellent. Very good. Thank you. Appreciate it. So by the way, this is our campus, but this is 4 years ago picture. So this has expanded just so much that it's a beautiful site in Northeast Florida that everybody is invited to join. That's where we do our work currently, and I think beautiful campus and beautiful city. I don't have any financial disclosures. Today we're going to start looking at craniopharyngiomas, and I think of course craniopharyngioma is the problem of the day, but we're going to use the process of decision making as an example. So when we have a problem, first of all we need to identify the problem, analyze such problem, develop solutions, and then following that we try to think about the best options to manage that, convert that decisions into action, and then follow up on the results that we have had, and then the circle goes on and on and on until one achieves like the mastery, and that decision making becomes automatic. Today, the problem that we're going to be talking about is a fairly complex one, which is craniopharyngioma. In terms of analyzing the problem, I believe that the key points for today will really be about understanding the location of the tumor and its clinical presentation. We will talk about surgery, which is one of the solutions, and we're going to talk a little bit about the different types of surgery that one can think about for this one. Surgical approaches, they are, certainly so different, and there is, in my opinion, more than one way to manage each almost specific subtype of craniopharyngioma. We're going to talk about pros and cons of those. And then we're going to go and discuss the endoscopic and nasal approach, which in my opinion is the approach of choice for the absolute majority of craniopharyngiomas. And then we're going to talk about results and next steps regarding this. So this is my hometown. This is where I was born in Brazil. This is a city in the northeast part of Brazil called Fortaleza in the state of Ceará. And I believe this is a pretty beautiful place, and I invite everyone to, to look at it on Google and Google Maps, and then consider visiting. It's a beautiful, beautiful state and a beautiful city full of very nice beaches. So craniopharyngiomas, I mean, just going back into history, like they are tumors well known to us and well described already for about 150 years now, where we have the understanding of its association between hormonal dysfunction, visual decline, and hydrocephalus. That's the classic clinical syndrome described in the late 19th century. And then in the early 20th century, Jakob Erdheim started studying the pathology of those tumors, and they were initially described as Erdheim tumors, as squamous cells that were residual from, an involuted craniopharyngeal duct or hypophyseopharyngeal duct, which gives the site of origin, quote unquote, of most adenomatous craniopharyngiomas. In 1909, we had the first transnasal approach to resect one of those tumors by Halsted, and then Cushing started to remove those as well through a transsphenoidal approach. But you see that only 14 of those cases were done transsphenoidally, and actually Cushing was very much against transsphenoidal for craniopharyngiomas due to the results that he had that were not satisfying, and such as he had the downslope on pituitary tumors for a period of time, only re-engaging in transsphenoidal late in his career as well. Transsphenoidal surgery continued then by the hands of Guillot and by the French school, and then Guillot and Hardy in 1960 modernized that operation with use of fluoroscopes to identify the sphenoid sinus. Yashargil modernized, neurosurgery with use of microsurgical transcranial approaches, and in 1990 he reported his series on craniopharyngiomas. And then, of course, in the 2000s, we got the development of endoscopic nasal surgery with teams in the US, Canada, Italy, and much more being important teams for that development. And then, of course, the team at UPMC, I think, had a gigantic impact. And you see here Dr. Kassan, Dr. Corral, Dr. Snyderman. When we look at, this is a paper by Dr. Ed Laws that everybody knows the name, very well-known, fantastic pituitary surgeon, recently retired. We have this paper published in 2013, demonstrates the operative mortality and the complete resection rate of craniopharyngiomas and factors that were considered to be associated with that. And then when we look at those, when you look first at the operative mortality, you see, a number of factors that have decreased operative mortality initially, operative techniques, and then antibiotics, radiosurgery in 1951, microscopes, and then the development of CT scans and MRIs. And then for complete resection, similar factors, CT, MRI, operating microscope, and then neuronavigation into operative MRI, and so on and so forth. The first thing, in my opinion, when I look at those two graphics as well, you see that the operating microscope was a key point here to be associated with further improvement. And then we had the second improvement was really the transsphenoidal approach. But they talk about tons of factors, but they don't talk about, in my opinion, what I think is absolutely key here, and in my opinion, should have been mentioned, which is in this period of time, 1980s and then ahead, we had the development of further understanding and better understanding of microsurgical anatomy with the works of Yashargil, Roton, Fukushima, Dr. Hakuba, and many others, and the development of skull-based techniques. And those 2 points were really key for the development of understanding and upgrading our results, not only in craniopharyngiomas, but in everything else in the skull base. So the surgical anatomy of craniopharyngiomas, craniopharyngiomas in this beautiful dissection on the Roton collection. are well demonstrated to be midline tumors that will be originating commonly from anywhere around the sala or the attachment of the infundibulum in the sala all the way to the third ventricle. So they can just follow that line of the so-called craniopharyngeal duct, and they will have a relationship with the structures in the sala region, with the suprasellar region, and the third ventricle region. And that can also lead to lateral expansions into the Sylvian fissure in close relationship with the uncus and the medial temporal lobe, and also inferior lateral with the region of the cavernous sinus, and also posteriorly with the region of the interpeduncular and prepontine cistern. When we look at a sagittal view, we can also identify the structures that will be related with those tumors. And in my point of view, there are a number of them. You always need to look at the scans, and you need to try to identify where those structures will be to optimize your results. So, of course, the first one will be the sala, but the second one, you can see the pituitary stalk, the pituitary gland, the third ventricle, the interpeduncular cistern, the chiasma and the optic nerves, and the anterior cerebral artery and the A1 complex. When we look at all of that, we need to think about it, because that's where the points of extension of those tumor or even origin will be located. So once again, suprasellar space or chiasmatic cistern, which basically is the reason why you got pituitary stalk, and then those tumors will be there most of the time. Third ventricle, interpeduncular cistern, prepontine cistern, and then extending in the anterior fossa, which is more commonly seen in big adenomatous cases with cystic components. In this paper, this is a paper by the group of Madrid, by Prieto and all. And the one point that I find always interesting, I always mention this paper because it helps to clarify a few things that I find very interesting. This is the classic, configuration, and you see that this tumor is occupying the suprasellar space, the chiasmatic cistern. It's not anywhere kind of occupying the third ventricle or so. But here, the second one, it has what we call a pseudo third ventricle extension. And what is it, pseudo third ventricle? This tumor is actually in the chiasm, and it's pushing the floor of the third ventricle upwards. And how can you tell that? You have to trace a line related with the mammillary bodies, and this line goes connects with a second line that goes from the aqueductus silvus all the way to the pineal region. And when that line has, when that angle is obtuse, or bigger than 90 degrees, you will have a tumor that likely is just pushing the wall upwards rather than extending into the third ventricle. And I find that important for preparation of reconstruction, but more importantly, so it's important to identify the relationship of the tumor with the walls of the third ventricle, namely so the hypothalamus. In this case, for example, we have a secondary third ventricular extension, and this tumor then pushed the mammillary bodies and the floor of the third ventricle down and posteriorly and open up this space, which means that then this tumor is extending into the third ventricle, and that can cause problems by adherences in the hypothalamus. And more importantly, so look at this type called infundibular tubercle. This tumor is mostly within the third ventricle, originates from the upper part of the stalk as it communicates with the tuber cinereum and the third ventricle itself. And then this very rare one that looks like Mickey Mouse because of the ventricles and its dilation, and so it's the so-called strictly third ventricular tumor, which is fairly rare. And those ones, in my opinion, because they have a floor third ventricle that is intact, I feel that they would be better approached with transcranial approaches. So different locations can cause different symptomatology. Basically, the ones in the cell can cause pituitary dysfunction. The ones in the infundibulum can cause changes such as obesity, diabetes insipidus as the most common of them. And then the hypothalamic syndromes with, once again, obesity, impact on the sleep-awake cycles in the body rhythm is also well known. Can also lead to incontinence, memory changes that oftentimes are associated with changes in the ventricular system, in fact. So this is a paper that we published, myself and my mentor at that time when I was in my fellowship in Toronto, Fred Gentili, where we looked to simplify the anatomy of this region of craniopharyngiomas. We basically divided it on 5 subtypes. The most common, the one that is not that common, but you can observe is the infradiaphragmatic type located basically in the sella. The second type would extend in the suprasellar space, and that would be the most common one, occupying the chiasmatic cistern and pushing the diaphragma downwards, actually. The type C would be the Sylvian fissure, the lateral type 1, which if this is a calcified area, in our opinion, a transcranial approach is more well suited. The type D is the purely third ventricular tumor, and type E is the one extending down, backwards into the interpeduncular cistern and the prepontine cistern. Why those classifications are interesting, especially so from a surgical standpoint, because it helps us to navigate the selection of surgical approaches. So when you look at surgical approaches, we have different types, including all the way from transcallosal to all the way to posterior petrosal approaches. And then, of course, each one of them has a different indication. When we look at the so classic, terional and its variations, namely so pretemporal, which is my approach or choice for craniopharyngiomas with extensions into the interpeduncular cistern, we would see that the anatomy that really matters to us here, it's the point that we observe here in this anatomical dissection that we did. So you see right optic nerve, left optic nerve, supraclinoidal ICA, A1, M1, PCON and its perforating branches associated with PCON, and then you got here the contralateral A1. Here you got the lamina terminalis, and that's been opening here. And you can see the interoptic corridor, the carotid optic nerve corridor, and we got the carotid oculomotor corridor. And those are the corridors that you use to get to the sella and then to the interpeduncular space. And why is that important? Because you see that the tumor will be blocked oftentimes by those structures, and you need to navigate through those windows. Therefore, you have to mobilize nerves and work around the vessels to get to that tumor. This approach can be used to remove suprasellar craniopharyngiomas. That was the most common approach in the Yashargil's series. And it's one that, we use from time to time as well, often based on the reconstruction in previous treatments. If I have concerns with reconstruction for the nasal, this would be my approach of choice for tumors like this. You can use to approach tumors in the interpeduncular fossa, and more importantly so, to manage those tumors here, the ones that extend into the Sylvian fissure, I believe that this approach is more appropriate to manage those tumors. Another subtypes, the ones in the third ventricle, purely into the third ventricle, but also the suprasellar ones. And you see, especially the ones that you see here. So that means inside the third ventricle and with a narrow narrow chiasmatic pituitary window. Those are tumors that, in our opinion, can benefit from open approaches, especially so a subfrontal transbasal approach that can give you this beautiful view of the optic nerves on both sides and chiasm, lamina terminalis, and then, of course, the sella. And then you can see that this midline corridor is well provided in terms of a visualization with this window. Once again, the challenge is that you have to work through narrow corridors between the optic nerve and the carotid and its branches. And then going all the way from above, a transcallosal approach, it is, in my opinion, often key for tumors like this one right here. And what is that? It's like tumors that are, mostly so in the ventricle and that are extending above foraminal Monroe. So this tumor could even be a little bit higher here. Those tumors, it's difficult to reach then beyond foraminal Monroe from below. And in my opinion, they're better approached from above, even if you need to work in combination of approaches like transcallosal, transventricular, and an endoscopic endonasal, if it is really a massive piece of tumor. But for those upwards extensions into beyond foraminal Monroe, I believe that this approach is a better option. And then we have the microscopic transsphenoidal approach, as a classic workhorse for many years that was successful and been successful for suprasellar tumors. But as you saw, the visualization is pretty limited. So what problems do we have? We have a narrow corridor, the brain retraction, which I think to use, retractors is not a problem. The problem is that a retractor is not really a retractor. It's more so like a brain holder And when you're retracting without arachnoidal dissection, you can really hurt the brain. It doesn't matter if you're doing vascular, if you're doing skull-based surgery. We do have limited visualization to some extent, especially working in the sala and the interpeduncular cistern space. And we require manipulation of neurovascular structures, which, by the way, we also going to be manipulating neurovascular structures with endoscopic and the nasal approach. However, we will see that you're going to have better visualization and much less manipulation of the optic nerves, if any manipulation of the optic nerves. And so those limitations is what led to the growth and the popularization of endoscopic endonasal for craniopharyngiomas, and that's why, as we discussed, I don't think there is much debate. That is indeed the workhorse for in most centers of excellence in over 90% of those tumors. So how to do it? And then using endonasal, dissections, we're going to be demonstrating that. Basically working through endonasal corridor. You need to focus your approach not more in the sala here, but more so in this space in the tuberculum region. And then you're going to see, this is a paper that we published a few years ago demonstrating the step-by-step on this. You need to, once this sphenoidotomy is completed, you need to identify your landmarks, both in the midline and as well as in the parasagittal spaces. And those will include the sala, the tuberculum region, or the prechiasmatic sulcus that goes from the superior intercavernous sinus all the way to the limbus sphenoidale, which is a very, very important structure for craniopharyngiomas. It goes from roof of optic canal to roof of optic canal. And the limbus is actually a durofold that you can observe separating the plenum and the prechiasmatic sulcus. And it will be a landmark to separate what we call a suprachiasmatic window and an infrachiasmatic window. And that's important because in craniopharyngiomas, we'll be mostly working below the chiasm rather than above the chiasm. So you don't need to have a really too big of a frontal exposure here. This next structure is key, the clinoid segment of the carotid. You can even see the distal dura ring, area in the proximal dura ring area here on the side. And this distal dura ring, in my opinion, must be exposed so that you have further visualization of the lateral parts of the chiasmatic cistern and identification of the oculomotor of the posterior communicating artery. The clival recess and paraclival ICA is more so for reference, but usually we don't have to work in that area. So you do the drilling of the sala, you do the drilling of the transtuberculum region, and then you can see here that you can get the medial aspect of the carotid, but we still need to mobilize a little bit of the optic canals. That's done, and then you can see now the distal dura ring exposed on both sides. You can even see the origin of ophthalmic here. And then we're going to go ahead and complete our exposure. And then we open the dura in the sala. Afterwards, we open the dura in the suprasellar space. And then we can coagulate and cut the superior intercavernous sinus and identify the anatomy that lies beyond this arachnoid layer into the chiasmatic cistern. And namely, so this is what we're going to be seeing here. This is the superior hypophyseal artery and its branches that will go to the pituitary stalk and to the optic chiasm, and the branches that will go to the pituitary stalk, they can be selectively resected. However, it's important to understand that if you do this on both sides, you're going to likely be leading to pituitary dysfunction. The other detail is that you do not want to do this with the branches that will be going to the optic nerve. For obvious reasons, you can risk visual decline after surgery. But the big advantage is that you see that those branches are well visualized here. The one important aspect as well is to be able to mobilize those branches with the arachnoid away from the midline so that you can work in your angle. And as we were discussing, the importance of that lateral exposure with identification and exposure of the distal dura ring, like right here, is there so that you can see what is lateral. So you can see the supraclinoid ICA here and here, and you can see the origin of P-cone on both sides. And that will be key because you don't want to just go pushing and pulling. This is not proper technique. You want to be able to first dissect the tumor around, make sure that there is no attachments to any of the vessels or the nerves or the superior hypophyseal artery, and then you can start, mobilizing the tumor away from the surgical cavity. It is a big problem if you try to remove by pulling this here, by pushing this here, you're gonna risk an avulsion of the pecon, and that's a pretty big of a problem there. So let's see surgery. This is a case of a 63-year-old gentleman that presented to us now. This is a case about 2 years ago. He had had surgery back in 2015, and then he had had surgery at that time, had a subtotal resection in another hospital. In 2016, he had surgery again with a nosy approach in another hospital that actually led to a gross total resection. The patient unfortunately had some visual changes in that right eye because of this. He was seen then to have progressive neurological changes with visual decline and confusion, memory, and urinary incontinence. So looking pretty much like a hydrocephalus picture. She had left homonymous hemianopia since the previous surgery, and then she had diagnosed hydrocephalus and had a VP shunt placed about a couple of months before her surgery. So he comes to clinic with this. You can see here a midline tumor with a cystic component going all the way to foramen on Monroe, and a calcification solid space in the inferior lateral space of the tumor, occupying the chiasmatic cistern and then extending into the third ventricle. And you can see here the mammillary bodies are, and this tumor is occupying all the way, but it respects the mesencephalic portion of the Liliequist membrane, separating the interpeduncular from the prepontine cistern, and goes all the way to the ventricle again. So what do we do for this? We do an endoscopic and a nasal approach. And I'm going to show you what we did. I'm going to skip a few of the nasal steps, but basically a nasoseptal flap was harvested, partial turbinectomies on both middle turbinates, a posterior septectomy, and then a large sphenoidotomy, as you can see here. And then we start here. This is me working on the base of the skull. You can see the sala, the clinoid ICA on the left, on the right. They're very close. They're almost like kissing carotids, which can be a little bit of a problem. But if you unroof that bone covering the carotids, covering the tuberculum, the prechiasmatic region in the optic canals, we're going to be able to get all that bone out of there to expose the distal dural ring on both sides, as you can see here and here. And then we can open the dura in the sala, open the dura in the suprasellar space, isolate the superior intercavernous sinus, so to be coagulated. And then with that, I can see the tumor readily right in front of me. And that opening the midline, and you can see that I'm going to do almost like a T-shape open, allows me then to have a bit more space mobilizing the carotids laterally. So unroofing of the carotids and dural opening that is extensive here, in my opinion, will help you to maximize your working corridor. You can see the tumor, and that's the first thing that I'm going to be working with. You can see the left superior hypophyseal going up here. Since this is a recurrence, third time surgery, we need to be careful to be able to, first of all, achieve some debulking before working around the cisterns. So here I'm just opening the arachnoids. I can see the ophthalmic artery on the right side, the optic nerve on the right side. And then using this feather blade to open this arachnoid, I can basically mobilize that arachnoid laterally and identify the superior hypophyseal artery on the right side here and on the left side. Once I have those two branches exposed, I can go and work in the tumor in the midline, because I know I'm not going to be hurting anything by working here right in the middle. And then with that, we start with some debulking. And as you see, like debulking with bisuction technique and mobilizing the tumor away from the right side superior hypophyseal artery a little bit more. And you see that I have this curette here, but curettes, I think, are very good and very friendly if used properly, and you got to use it as a dissector. So from outside to inside, much more often than trying to curette. This is using the Myriad device, debulking the tumor with it. It's a microshaver that helps, in my opinion, especially with craniopharyngiomas. And with this, you can mobilize the tumor. And then you got that part of that calcified part out. With that, I can basically work inside the tumor after popping the cyst. And then we can see the calcified portion of the tumor. Now we got to work more carefully to identify Liliequist membrane. And you can see here the posterior cerebral, We're going to be able to see the superior cerebellar and P cone in a moment. And there you can see. So you see
Excuse me,
posterior
John.
cerebral, superior cerebellar,
Oh,
and P
Joe.
cone. Yeah?
Yeah, sorry to interrupt. You have, I'm just want to tell you, you have plenty of time.
Oh, no, okay, thank you. So posterior cerebral, superior cerebellar, P cone, and the third nerve here. And then the same thing on the other side. And with the Lilliquist membrane preserved, we can mobilize the tumor upwards. You can see that in this case, the Lilliquist membrane is not fully preserved, but it gave me already what I needed it to mobilize this safely. With this, I can mobilize this tumor from, once again, from lateral to medial, so away from the walls of the third ventricle, which on the left side, I cannot yet see it because I got the superior hypophyseal in front of me here. So I can mobilize a little bit of that. And then I can, once that's mobilized, under visualization, I can retract some of that capsule that will be attached just to the walls of the ventricle. And then I got to peel that from the wall on a very gentle fashion, so not to cause any injury to the walls of the third ventricle. And then with that, we're going to remove most of this tumor. You can see that coming out right there. And then we're going to see this beautiful view of the ventricle. And then here you see foramen Monro on the left, on the right, choroid plexus, you can see the fornixes going this direction, mammillary bodies, and here you're going to see that there is a little bit here. So this is residual tumor, calcified piece. And then we're going to take that out again. And then what do we find after we do that? But that's it. So that's the aqueductus silvis that now you can see. And all the way in the back here, that's the pineal gland, okay? So that's the whole view of the third ventricle. And now with a 30-degree endoscope, I'm just going to inspect that cavity. Left side, everything was clean, but here on the right side, I saw this. So I still want to clean that area. So I'm going to try to mobilize that all very gently. I don't want to cause an injury to the P cone as you see it right there. And then I'm going to try to just clean that very, very gently. I'm going to get that most, the last piece of it right here in a very, very gentle fashion. And there you go. And then after that, we can proceed with reconstruction with durasubstitute fascia lata that was harvested from the right leg, and then the vascularized nasoseptal flap. And this patient did clinically very well and was discharged in the following week. You can see here basically this is you got the pre-op and we got the post-op images, pre-op, post-op, and pre-op and post-op. This patient has now been followed for more than 2 years and is doing clinically very well. A second case. This is a patient, 60 years old that came to the emergency, as you see, in August of 2022, had changes in the mental status, forgetfulness, decreased concentration, hallucinations, looking as a infundibular syndrome with a mix of a hypothalamic syndrome, and had this CT scan demonstrating this large mass. And you can see here that this tumor is really pushing, has a very unique relationship with the hypothalamus on both sides. And it's inside the third ventricle. And it has this relationship with the chiasm. So what is the challenge here when we look at the sagittal specifically is how high this tumor goes just behind the optic chiasm. And that means that as you work below the chiasm in the infrachiasmatic corridor, the utilization of 30-degree endoscopes will be important to clean that up. And also that you're going to have to find ways to bring that pituitary gland downwards so to open up your space. But the most important point in cases like this is to understand that if you don't work on it very closely, you may end up leaving some tumor just here in this upper corner, just because of a blind spot in that region. So, but that can be done, and that has been demonstrated. This is a paper that we published at the time that I did my fellowship with Ted Schwartz in New York. And this chiasmatic pituitary gland window, as we call it, really in experienced hands, it doesn't impact it very much. So that upper space that I was demonstrating before is one that you can achieve that resection in experienced hands, but you got to pay attention to it. Otherwise, that's where your residual tumor will be located. So let's see the surgery. This is almost 2 years ago now. Nasoseptal flap, removal of the posterior septum, sphenoidotomy, and then after the large sphenoidotomy was created, we got once again the base of the skull. We're going to be working to do the cellotomy, the removal of the chiasmatic region or the tuberculum region bone, and then once again achieve that exposure of the distal dural rings that we talked about, which once again to me is key. So you got the distal dural ring on this side, you got it here on this side as well, and then on this case, you see that the window between the two carotids is much wider. It's much, much better than the other case that we just saw. So that also should help you to guide your approach and your bony exposure. So you got to pay attention to your preoperative scans to make that call. Then the technique is absolutely the same, ligating the superior intercavernous sinus and then proceeding with the transection of the sinus. You can see the tumor. Really, this is the pituitary stalk, and this tumor is really coming from the most distal part of the stalk going into the tubercinarium, and then you can see the optic chiasm that is just placed forward as a prefix chiasm in this case. I can go ahead, open the tumor capsule, open the infundibulum, which in this case is taken by the tumor, so there is no way to achieve a gross total resection and infundibulum preservation in this case, in my opinion, or in my hands. We're going to be removing this tumor, and as you see, initial debulking, the chiasm starts to fall, and then that's good. It means that the tumor is falling progressively. I can remove some of this mass here, and then you can see that with progressive debulking, I can get more space. The chiasm is now relaxed with a 30-degree endoscope. I can mobilize that tumor. So I'm looking up with that endoscope now, but still preserving the capsule and the infundibulum there. Okay, infundibulum which was made larger by this tumor. So I got to continue mobilizing that. And now I go in an extracapsular fashion, try to separate those attachments. And you're going to see, because that's actually the infundibulum, that there's going to be no unique place of separation. So I'm going to have to mobilize that inferiorly as much as I can, and then decide on a plane to create a transection. So here we go. So I'm removing that part of the tumor there, completely separated any residual connections. And now bringing that down will allow me then to remove that superior component that we had discussed. And then I have that connection there in the top that I still need to deal with. And there you go. So some of the capsule there. Once again, removing that with gentle mobilization that's already pulling from the third ventricle. And then you can see here once again that nice view of the third ventricle after the tumor is removed. There you go. With 30-degree endoscopes. And then you can see that this left side here, I did bruise a little bit the walls of the third ventricle. Reconstruction is done with dura substitutes, fascia lata, and the vascularized nasoseptal flap, and this patient did clinically well as well. With panhypo after surgery, that is being managed with our endocrinology team. And then as you can see with those two cases, with adult patients that will have availability and access to pituitary endocrinology, such as we do have here, I am very much in favor of attempting to achieve complete resection of those tumors. For case number 3, this is a patient, international patient that came with, she had 2 surgeries for this tumor and had presented with visual decline again. You can see this typical pattern of bitemporal hemanopsia. So once again, a patient with 2 recurrences and comes here now for a 3rd surgery with this image. And when you look at this scan, you can see the nasoseptal flap. You can see a cystic, predominantly cystic mass in close relationship with the optic chiasm. And with compared to the other 2 cases that we just saw, this would be an easy case, right? Like, I mean, go pop the cyst, mobilize the capsule. The problem is that this patient had had 2 surgeries before, and that is something that can impact us in terms of our availability to mobilize the tumor completely. So this is just my ENT colleague doing the approach, and this is me now again drilling the base of the skull. And you can see, because she had had surgeries before, the bone is already a little bit different from the other pieces of bone you saw before. All this drilling to achieve that same trapezoid shape opening, to expose the most medial segment of the carotid, unroof the optic canals on both sides, and to remove this piece of bone. Oh, by the way, this case here, I did it on the same day that I did the first case. So this case followed in that room, and the approach was basically the same. So if you follow that, cook recipe, you're gonna be able to get that done well. So you saw the exposure to the carotid, just to do a ring on this side. We're gonna do the same on this left side. And this is always done using a diamond burr. This is, in this case, a 3 millimeter diamond burr that helps me to work without much concern with the dura. So opening that arachnoid and the dura, ligating the superior intercavernous sinus. And please do not minimize the superior intercavernous sinus. In some patients, it can bleed quite a lot, actually. I don't really like to remove this with this Carrison-like instrument, but in this day I did that. I suggest to work with more like a scissor instrument to resect the dura. And then with the arachnoid being open, you can see once again the cystic and the chiasmatic system right there, popping up that cyst of this tumor. And then you just have to open up the space. And then you see the tumor in the back right there. Here. And then after that was removed, you can see the cellular space and all this fibrosis with the optic chiasm here right in front. It makes surgery more challenging. So trying to mobilize that and trying to separate that was proven difficult, just because of all the attachments with the arachnoid. So dissecting that in a very microsurgical manner, as you see, it's really microsurgical dissection, done under endoscopic visualization to separate the superior hypophyseal artery. It's difficult, after so many surgeries and also after radiation, especially. So you see that being done right there. The capsule is then progressively resected. This is the optic nerve on the right side, and just trying to find a plane to remove that. And you see that going on a very stepwise fashion, trying to find a plane. And then here the optic nerve, and this is going to the third ventricle. So that's opening up that space between the optic nerve and the tumor. And then going to be mobilizing all of that to kind of try to find if there is any residual on the top. So you see that very difficult to remove a capsule in this case. I'm just working around, trying to see what we would get. And then by mobilizing this arachnoid, I can see the optic nerve, but it's attached to that arachnoid. So you got to be careful. I brought it down to try to look up in the lamina terminalis from below, which is a technique that sometimes you can use, but you can see here the acon complex. And I said, okay, no, this is too much. I don't see anything. This is already pulling it, and that must be done very carefully. So you see that this optic chiasm descended significantly right here. I got that tumor there that I removed, as you can see there. But in this case, there was a little capsule that was residual attached to the optic nerves. So this was a near total resection, but not a gross total resection. Reconstruction was done following the same principle. So I do like the combination of the substitute inlay and the fascia lata onlay, and then this nasoseptal flap. And this is the post-op scan. You see that the tumor is removed, that there is a little line, front in the top. So I think that this residual tumor capsule, and that patient actually received proton beam radiation therapy afterwards. And she is now more than 2 years out, and she's doing clinically very well, with no signs of tumor recurrence. And then this patient, 72 years old male, also with a previous history of orthozygomatic approach back in 2008, so 16 years later. comes to clinic with this image. So take a look at this coronal scan here, and you're gonna see this image. So mostly a cystic component on the left, but on the left going all the way to this junction of the bifurcation of the carotid. So this is M1, I'm sorry, A1 and M1, supraclinoidal ICA. And it would seem just like as a cystic component, but sometimes the image may trick us. You're going to see that in this case, it was calcification located just in contact with the basilar tip, which was actually what made the surgery more challenging. And that's not well demonstrated here in this scan. So this is the video. Let me skip this. So the approach that we discussed, once again, sala, prechiasmatic region, all the way to the limbus. You don't have to go more cranial than the limbus. And then unroofing of the carotid and unroofing of the gistodura ring. Those are the key points here. Once again, you got to see the carotid on the left. I'm removing here just this part of the middle clinoid process on this case, removing the lateral tubercular strut. And then we can get all that exposure completed, removing here some of the bone in the tuberculum. And then you can see carotid, gistodura ring is exposed on both sides, especially so on the left. And especially so on the left, because that's the point. This is the lateral tubercular strut, by the way, because I'm gonna need to see that carotid bifurcation on the left side, okay? So this is completing that unroofing. The limbus is right there. And this is the exposure, the completed exposure here. Opening the dura in the sala, opening the dura in suprachiasmatic space. You can see the arachnoid of the chiasmatic cistern, and then opening the optic canal to see the ophthalmic artery and the optic nerve on the left. Then I'm just gonna open this arachnoid, and then we're gonna see the tumor. We're gonna see the pituitary stalk here. I'm gonna dissect that. So to try to preserve the pituitary stalk, which I have a very low threshold removing that, by the way, but in this case, let's see what we're gonna have. So removing all of that. And then I can see that in this case, actually, I think I'm gonna be able to preserve that stalk. So I'm gonna just work and open that arachnoid to identify the superior hypophyseal on both sides. You can see the one on the right here. And then I can see the one on the left, but I wanna open that arachnoid so I can see it better. So superior hypophyseal on the left, I'm gonna open that space right here. As you see, just opening up right there. And then I can work to remove that, part. So the cyst is gone already, but you see that we got calcification. So this is a typical adenomatous tumor. And as I said, they can have calcifications that can be quite tricky. So working to peel that away, we always have to remember anatomy. So you peel that away from the liqueous membrane up. So go from down up. And you have to remember the trajectory of the, of course, basilar tip, PCA, PCOM, and the thalamoperforating branches. So here I have identified the PCA on the left side. And how do I remove this tumor then? I have to see the basilar tip that is just behind the stalk right here. And I need to remember the anatomy of the perforating branches that will be arising from it. So I need to peel that away from down up and from ventral wall of the PCA and basilar tip, avoiding the manipulation or significant manipulation in the posterior and superior walls of the PCAs and basilar tip, because that's where the thalamoperforating branches will be coming from. So as you work around that area, I'm going to be working, you see, just behind the pituitary stalk and working to mobilize the branches coming from that region. I mean, the tumor coming from that region and mobilizing that away from the mammillary bodies as well. So as I go in that region, I just continue working. You can see here the ICA bifurcation and the capsule of the cyst is now being mobilized. That's done without much problem. And I can now just go as I mobilize and transect some of the attachments. And then after done that, I can basically continue my work, peeling it, always keeping in mind the thalamoperforating branches. I can go around to just separate that from the third ventricle. And then I can start to better see the anatomy. And in this case, there was no extension into the third ventricle, so the floor is intact. And then this tumor is almost completely mobilized. I just have to find a plane and an angle to separate from the mammillary bodies and then to separate from the branches in the basilar. So I need to get a better view still. So I'm going all the way there. And then working little by little from one side and the other side, you can see here some of the perforating branches that we were discussing. I can work by respecting that plane. So to find the vessels is key, in my opinion, because as we know, like if you preserve the layer just on top of the vessels, you're going to be able to achieve this degree of resection. So you see here PCA, the perforating branches preserved, the mammillary bodies that had been affected by the tumor itself. And you can see the ICA bifurcation was just up here. And we can identify with a 30-degree, the third nerve, uncus, PCA, SCA, basilar tip, and then all that anatomy on the right side as well with PCA, PCOM, and the third nerve right here as well. And then looking up, we're going to see that the third ventricle floor is intact here. And you don't see much opening there. The opening is there, but that's because of the previous surgery. Reconstruction with, once again, durasubstitute. And in this case, we decided to use durasubstitute and a flap, I believe. And unfortunately, this patient actually had a leak despite having a lumbar drain. So had to go back to surgery and place, durasubstitute, fascia, and a flap. This is the post-op coronal scan that demonstrates gross total resection here, and then here once again, gross total resection again. And with preservation of the pituitary stalk. So in terms of results, usually I used to present this, but I have to say, like now we're even one step ahead, right? So in 2010 to 2020, all the challenges and all the let's say most of the problems that we used to have with craniopharyngioma surgery, I think were overcome, like especially so the issues with anatomy, technical instruments, and so I think all of that is very well described, in this stage here. The leak rate is an ever improving, I think, issue. We have to continue working to do better on that. And I guide you all to the works of Ted Schwartz. I think he does a great work discussing reconstruction of those. I don't use a gasket seal because I see I like to expose the carotids, but I like to use there is a button graft. There is basically all the techniques that can help us with that. This is a series of Toronto. I did my fellowship there, and we had here with 43 surgeries. You see that first surgeries have a much better gross total resection than recurrent surgery, and basically that is also true when we look at the literature. This is a paper that we published 3 years ago or so, and we can see that CSF leaks are actually the one problem that is still ongoing when we look at the series published between 2010 and 2020. But those numbers have improved, and right now I quote to my patients an about 5% chance of CSF leak. Recurrence and progression remains a reality, especially if you try to preserve the pituitary stalk. There is a higher chance, that's well demonstrated in this paper by Ted Schwartz and led by my good friend Edgar Ordones from Colombia, that demonstrated that, when we look at patients that had a gross total resection with stalk sacrifice or stalk versus stalk preservation, that yes, of course, the pituitary function is preserved in about 50% of patients only when you preserve the stalk, but there is also there is a higher chance of recurrence on the patients where the stalk is preserved. So I think that's important to discuss with the patients, and that's why, as I said, I'm more inclined to go for gross total and work with endocrinologists than to expose to subtotal 50% chance of not being successful for hormonal preservation. It's still having a higher chance of recurrence. And when you're dealing with recurrences, it's important to mention that it's probably to be a long-term problem rather than a one-stop fixed issue. And then you can see that 1 in 5 patients did well, but also 1 in 5 patients required multiple interventions for control the disease. And this is to illustrate this. This is a 48-year-old patient that, once again, recurring tumor. He was initially treated in another hospital 6 months before being seen by me in clinic. His MRI demonstrated he had, by the way, surgery and radiosurgery afterwards. And then he presented with some of the clinical changes seen here. And this is his, MRI initially that demonstrated this mass. And the outside facility team did an endoscopic and a nasal approach. In my opinion, they did a good work, but the tumor grew back, as you see here. And they did radiosurgery. And then despite radiosurgery, the tumor continued to grow. And you see there that there is this area of calcification here and the cyst that is growing again there. So what do we do with this? We do surgery, but this patient had an intranasal and outside facility, had this component extending to the sylvian cistern, and had radiation as well. So I had concerns with the reconstruction in this case. And therefore, I chose this time, actually, instead of doing a endonasal procedure, to do a pterional craniotomy. And this is what is done here. So the usual, pterional, draining the chiasmatic cistern, doing a partial opening of the sylvian fissure, following the, classic steps as we're all familiar with, following the M2, then M1 branches. And that's going to take us all the way to the chiasmatic region. And then I can basically see now the supraclinoidal ICA, the optic nerve, and then the cyst is drained. And after the cyst is drained, we got to see the tumor, the solid part underneath all of that. And then I can get to basically work to immobilize the remainings of that cystic component. Following, you can see here the third nerve. And then working between third, carotid, and optic nerve, I can work around that cyst. So as you see, endoscopic is an excellent option, but it's not the only option. And in cases that I'm concerned with the reconstruction, such as in this case, I feel that an aggressive resection with a transcranial approach or endoscopic, but in this case, because of the reconstruction with a transcranial can lead to excellent results as well. So the tumor being removed, and I see I'm going all the way up there to see if any extensions around the base of the skull. Sacrificing the pituitary stalk right there. And you see just removing the last attachments in the base of the skull. That's it right there. And then that solid component is disconnected and removed. And you see using the interoptic space. And then I'm just gonna go, this is the attachment of the infundibulum here. So I'm just gonna go and work around it to basically transect the arachnoid, identify it well, and coagulate that area. So you see the stalk right here, and then that was all coagulated. So that's it, the coagulation right there. And this is the end of the resection. This is the pathology. So you see here the typical palisadian epithelium, keratine, stellate reticulum. That's an adenomatous craniopharyngioma. And then the post-op images that demonstrate, a gross total resection of this tumor with no signs of complications. And then here, this is the post-op in November. And you can see here, adequate resection. And more importantly, so the patient, of course, had pituitary dysfunction, pituitary hypopit, and his own replacement, his vision improved. He is following endocrinology and having a normal life, with the exception that he is taking the medications. So in terms of next steps, what goals do we have? I think that we have to ask ourselves how much aggressive we must be surgically, with the advent of, of course, the use of radiosurgery, proton beam, carbon ion, all of that. We need to better understand the cognitive impaction of the surgeries that we do, not only the gross, walking and talking examination, identification of tumor subtypes, and treatment selection that is likely to be impacted by the factors above. So here, this is a study, a review by the group of Vancouver that, basically describes the impact of gross total versus subtotal and radiation. And in my opinion, when I look at this, it doesn't kind of like answer, it doesn't impact my decision making in terms of treatment care at this point. But it does tell me that for the patients like the ones that I showed from Ecuador, that if we can't get gross total resection, the near total resection followed by radiation can provide good results as well. That's my take from this here. I wouldn't advocate for subtotal resection radiation in most patients for sure. I would not advocate for that. But this is a 52-year-old male that presented with headaches, intermittent left visual decline, visual changes, and then had steroids, and then presented with this here, and you see here this tumor. Basically, cystic component was basically the big thing on this case. Had a small solid component here attached to the pituitary stalk, and all of this. So had all this cystic component. Okay. And this will illustrate well the issues of management of this tumor. So this one, a little bit of a different animal, so to say, in terms of tumors, of course. So this, as I said, this tumor is a little bit of a different animal, but the technique is the same. So I'm going to skip those steps. You guys are probably tired of watching this exposure so many times today, but as I said, it's the recipe for success, in my opinion, is a proper exposure. So this is a cystic one. I didn't go too much. You see that I really didn't expose the distal dura ring here on this side. I did more so on the left side. And I'm gonna go, I popped up the cyst, created a space, and here you can see the superior hypophyseal artery. And I'm gonna be preserving that branch, of course. But you see here that solid component is just here. And I need to see, because I need to see the pituitary stalk. I want to see if we can preserve that stalk in this case. And you see, like, the tumor is, the cystic component is all drained. I didn't chase the capsule because the frozen section had already demonstrated a papillary tumor. So in those cases, I'm going to see for a moment why I tend to be, nowadays at least, a little bit more conservative. But then the challenge was really to work around the pituitary stalk and the capsule. So again, here the tumor just mobilizing up and down, creating a plane of separation with the infundibulum, and I'm going to transect that. So that you go, that's transected, the tumor comes out. And I'm going to go to try to see if I can peel some of that capsule, and I go, but there is some of it that is just too attached. Then this is the pituitary stalk. I go to work a little bit more on it to try to see, but you see, this is all a little bit of kind of like thin layer of tumor on the top. So I try to peel that and find a balance between peeling that and leaving tumor, so I don't go too crazy on that one. And biodesign, substitute, and a vascularized nasoseptal flap afterwards. So you see no fasciolata on this case as well, but this patient actually did well without a fasciolata. So this is the final result of the surgery with a post-op scan that demonstrates, a very good decompression of the cyst. But what happened is that this patient has a papillary, and then on follow-up, 8 months after, he did well initially. He didn't have additional hormonal dysfunctions. And he did have temporary diabetes insipidus, but improved. But 8 months later, he presented again with that recurrence of that cyst, and now he's actually being managed with this therapy, which is or identification of BRAF mutations in papillary craniopharyngiomas has led to the potential to utilize those BRAF inhibitors for the management of those tumors, and there is significant evidence that signature follows that simple principle. So papillaries have the BRAF mutation, and adenomatous will have basically the CT-NNB1 mutation. Therefore, it shows different lines of origin and different signatures. And then the patient that I just showed you is now on that. The cyst has decreased in size just with the medication. And at this time, we're just following him with that medication. And there are new targets that we're studying. This is a paper that we published in 2022, looking at the pathways for adenomatous craniopharyngiomas. I think what we have now in terms of options for papillary is good. It's still very expensive, and it's still undergoing trials led by Priscilla Brasianos from Boston. But for adenomatous, we really don't have many options yet. So this is still to be better understood and better evaluated. So as conclusion, cranial endoscopic represents the approach choice for most craniopharyngiomas. You need to understand the surgical anatomy, experience, and multidisciplinary teamwork. Maximum safe resection for preservation of optic nerves and hypothalamic function. The pituitary stalk preservation is possible in some selected cases, but in my own philosophy, I don't, if there is good endocrinology and if the patient already had a recurrence, I think you need to consider the impact of preserving the stalk. That will lead to higher chance of recurrence over time. Adjuvant radiation therapy may improve control rates in cases where gross total resection is not possible. And recurrences are not uncommon, especially after subtotal resection. So you need to have long-term follow-up. That's absolutely key. And then, of course, we got new modalities, and the understanding of tumor biology is increasing over time. And I do believe that, such as we have BRAF inhibitors for papillary, that we're going to have more for adenomatous as well. And then we're going to have to better understand how those will play a role in the management of those patients. So just to finish here, I like to share this line by Ayrton Senna, who was a Formula One driver, from Brazil when I was growing up. And he would share that I believe in the ability of focusing strongly in something, then you're able to extract even more out of it. It's been likely this all my life. It's been only a question of improving it and learning more and more. And there is almost no end. And as you go through it, you just keep finding more and more. It's very interesting. It's fascinating. So basically, I think this just reinforces the importance of focusing. You need to, find your passion, find your ground, I think subspecialization is very, very important. And the reality is very simple. The more you do, the more you pay attention to quality and your results. I think the more and the better you get in many things, including neurosurgery. So with this, thank you very much. I think the team that I work with, I invite you guys all to visit our lab in Florida, and to thank the team that work with me, and to invite for the courses that we have. So this is my email. I can also put my personal email here, but thank you all for the attention, the opportunity today.
Thank you very much, Dr. Almeida. Juan Lee, are you there?
Yeah,
Juan
yeah,
Lee?
I'm here. Yeah. So,
Okay.
yes. So, yeah, thank you, Dr. Almeida, for your wonderful lecture and nice video.
Thank you.
Yeah. Are there any questions from the audience?
I think Takashi has a comment, right? Do you have a comment,
Yeah.
Takashi?
Okay, so thank you, Dr. Almeida, for that presentation. I'm Dr. Kon from Tokyo, Japan. Still, surgery of craniopharyngioma is still difficult, and the more recurrence for the recurrence, great adhesions, the pituitary stalks, and the criminological management is still difficult. So, as for adolescent cases, so we delay. Even if the residual tumor, so we deter to do gamma knife or radiation to avoid visual disturbance. So as delayed as late as possible. So, but still, do you think so? Based on the microsurgical anatomy, uh, the resection rate became much more than before, but still it's difficult adhesive cases. What do you think for the radiation, the gamma knife treatment for residual craniopharyngioma at this point?
I couldn't agree more with what you just shared, Dr. Cohn, and thank you very much for your, comment and for your words. I follow exactly the same philosophy. I know that there is a lot of conversation and controversy. There are, some colleagues that advocate for actually, subtotal resection followed by radiosurgery, or, even proton beam. In my point of view, I don't think that that's the way to go, for a few reasons. Number one, that as you mentioned, craniopharyngiomas, I think our results are improving, but we all know that is much more so a chronic disease, that I don't ever tell the patient that you're cured. We clean everything and you're cured. I don't feel
Yes.
ever that I will feel comfortable to say that, because we have all seen patients that come back after 8 years or 10 years. But I still believe that gross total resection is the best tool that we have to provide them with the best chance of long-term disease control. But anyways, if we think about subtotal resection, then we would be using radiation for the areas that we want to avoid surgery. But that usually is close to the optic chiasm, close to the hypothalamus, and close or at the pituitary stalks, which is often the center of origin. And then if we do radiation for that area, the pituitary stalk and pituitary gland, we all know, I mean, the literature is very clear that, the reported rate of pituitary dysfunction is of over 50%. But in my opinion, if we follow those patients long enough, that rate of pituitary dysfunction is going to get probably to 100% over time, because we just burned the gland at the stalk. The optic dysfunction is also a reality that has been improving, but we all also know that after the initial 3 years, so between 3 years ahead, there is a significant change of visual dysfunction, which is very difficult to treat with radiosurgery in that area. So I know some people are trying proton beam, but I honestly don't know if that will make a significant difference in that outcome. So I think that radiation is a very good treatment for the cases where you really was not able to achieve disease control and the patient's having recurrence, and that it's not a papillary. Because if it is a papillary, I think the BRAF inhibitors are a better tool than radiation, actually. And that's been the philosophy here. So trying to delay, such as you mentioned, radiation to the best of our abilities, but when we get like some international patients that may not be able to follow as closely, we have to consider, well, if this is the one stop that they have a chance to be managed, we got to think about that. The other thing that you mentioned that is very, very, very important is the endocrinological follow-up and control. If your patient does not have the ability to follow up with endocrinology, I have concerns that it doesn't matter how good of a surgeon we are, that patient will have a poor outcome, because it is very difficult that that patient will not need some form of hormonal replacement. It is very difficult that that patient will not face some issues over time, independently if we did gross total resection or not. So that's something that I'm original from Brazil, and when I think about the issues that I had in the countryside of Brazil, so not in the big cities, that was the big issue. I mean, you can do a beautiful surgery, but the patient will have difficulties in following up with endocrinology, and that can kill your patient, basically. So those are my points of view regarding that.
Thank you. Thank you.
Thank you, doctor. I mean, I have a small question. What about your opinion for the young patient? Like, as I know, some pediatric neurosurgeons still prefer the transcranial approach for the craniopharyngioma with the patient, the younger patient, like younger than 10 years old.
I think that then that goes to the anatomy of the case. I mean, so not only the anatomy of the tumor, but also the anatomy of the nasal cavity. So for very young patients, especially the ones younger than 5 years, it's really a very narrow corridor, and it makes this surgery that is already not easy, even more difficult one. So I would be inclined to consider transcranial as well. And as we discussed, I think transcranial approaches like the Tiriono approach is, first of all, that was the first approach that I was trained on during, especially in pediatric neurosurgery cases. So all the craniopharyngiomas we were doing at that time, like 15 years ago, in the center where I did my training, were done through Tiriono approaches in this region, and the patients did well. So nowadays, with the work we've been doing with endoscopic, I would look at the anatomy of the nasal cavity, at the anatomy of the tumor, and they make that decision. And that's in terms of approach only and anatomy only. But in terms of the hormonal function and hypothalamic development of that patient, I think there are also details that we need to consider. And those details will include how radical we're going to be early on with that patient. I think that especially in the very early onset, it may be interesting to try to mitigate extensive resection that could lead to more significant hypothalamic dysfunction, especially due to the risk of morbid obesity that can follow. But that needs to be balanced with the impact of multiple recurrences. But I think in the pediatric population, it's literally a different, beast type of tumor. And that's why I focus on adults here, because I think they're very different in pediatric. And my current practice is really focused on adult patients.
Okay, we have a question, Juan Lee, excuse me for interrupting, from Lal Riemann. His question is, in cystic cranio, there is recurrence. What can we do after transsphenoidal resection in such cases, and to preserve CSF leak, this fasciolata graft should be inlay or onlay?
Well, so I think that it really, well, in terms of the cystic craniopharyngiomas, I think it really depends on what is the technique that is being done. As I showed the last case that I demonstrated, I did have a recurrence, but that was because I really didn't pursue the aggressive resection of the tumor capsule. When you're able to do that, and of course you're not able to do that in all the cases, but when you're able to do that, it is my impression that the recurrence rate tends to be lower. Not zero, it's never zero, but lower. So if you, however, use the philosophy of just opening the cyst, draining the cyst, and that's it for the surgery, the chances of recurrence is much, much, much higher. So I think that's a point for consideration. Now, the other point is, let's say that's a cystic tumor. You went ahead and you did, the best surgery possible, removed as much as the capsule as possible, and you still have a recurrence. I think if it is a papillary, if there is availability to that BRAF inhibitor, that's a great choice, but I'm very realistic, and I understand that that's definitely available only in very selected places for very selected patients with, honestly, like good insurance and a good amount of money nowadays. And therefore the options are limited. So if you don't have that, and if your patient has had multiple recurrences and you cannot remove that capsule due to proximity or any other issues, then I think you have to consider the possibility of radiation. If you have a big, cystic tumor that is always popping up, in the pediatric population, especially, you have the options of using, the fenestration of the cyst and then modifying factors such as interferon alpha and then TNF, and also even like I forgot now the name, like the TB medications that they inject as well. But in the adult population, that is definitely less common. And the question in terms of the reconstruction, the techniques can vary, and they do vary among centers. The technique that I favor nowadays is a dural substitute that is, malleable inside if you have that available. I like the one, the Duragen. I like the one for that part to reconstruct the arachnoid, and I have no relationships with that industry. The second one can be a more pliable one, like, Biodesign, Duramatrix, Durapair, any of those. But I really like fasciolata for those. I do think fasciolata makes a difference. And if you don't have the dural substitutes, you can rely on the fasciolata inlay and onlay and the vascularizing the septal flap. As you see, I haven't mentioned fat because I don't use fat for those cases, but I have amazing colleagues that do it and they have great results. And I think that can be an option, especially if you don't have availability for dura substitutes, which are expensive. And in those cases, my colleagues, like the group from Napoli, Capobianca, Cavallo, and Domenico, they would put fat as a first space to kind of occupy that tumor space in the intradural component, and then inlay component of fasciolata, onlay fasciolata in the flap. And that gives good results as well.
Okay, Juan Lee, we have one more question. Okay, Juan Lee, before we move on, Harshad, looks like you've been waiting for a question. He's an Indian neurosurgeon. Harshad, you have a question or comment?
Hi. Hi, Professor Almeida. Excellent presentation you have given. Wonderful demonstration and techniques of
Hello, thank you.
craniopharyngioma. Wonderful and great. Do you take help of ENT colleague to do all this drilling and the procedure? That is one thing. And the second is that every time do you have to mobilize the carotid artery or drill the carotid artery when you go to the this area? And third thing, if you see a calcification and calcification feels like adherent to either the artery or to the 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 stem, what do you do? You leave the behind or you try to remove it? What how or if you remove it, how do you remove? If it is adherent to pituitary stalk, what do you do?
So can you repeat the first question, Dr. Harshad, please?
No, are you taking help of ENT colleagues
Oh, sure.
for that?
So yes, the answer for that question is yes. So that's based on the way that we work in the hospital that I am, and I think that can be very helpful. Of course, during the surgery for the approach and the closure, but I think it's also very important for the follow-up. I think we do benefit a lot from working with ENT. I have to say that when I was practicing in Brazil and when I was in Toronto as well, we did have ENTs, but they would not be always available. And then for craniopharyngiomas, we would do those cases by ourselves as well. And that also is a way to do it. I would just suggest that we have, it's good to do, if not with a ENT, to have another neurosurgeon just because it helps with the flow of the case, I think. More so than just a trainee, because to navigate with the camera can be difficult as well in those cases. Regarding the second question again, you were discussing about the calcification and the carotid exposure. So
Yeah.
I think that depends on the case and that depends on the surgeon. So to me right now, it would depend on what patient is this that I'm treating. Is this somebody that has had multiple recurrences and has had, more problems before? And is this somebody that I feel that this component, which is a very challenging one, will play a significant role in new recurrences of this case? If the answer to that is yes, I would consider checking the possibilities of removing it. And calcified tumors in that area can be very, very challenging because you cannot mobilize it out. Initially, you need to thin it out. And then to thin it out, you have to use a drill, and you need to be very careful that proximity. But I have to say that for those calcifications, usually the answer, a calcification that is in close contact with the carotid that I cannot mobilize more easily, I think that can be a problem. And nowadays, I'm more conservative than aggressive with those. And that's with the carotid or with the optic nerve. But with the pituitary stalk, I would probably remove the stalk to get the piece out. And then that would go. But the calcified tumors, they are a problem for everybody, especially in the pediatric population. And I even had a case recently that was seen by a colleague of mine here. Then went all the way to Stanford to talk with Dr. Fernandez Miranda, Juan talked with me, and then it's one of those patients that may be very well the ones that, first of all, will never be cured, and I think probably will never have a complete resection, and will be a chronic problem that we have to find ways to mitigate symptoms. But it's not all craniopharyngiomas that we can remove completely, unfortunately.
I agree with you, whatever you say, and I feel the craniopharyngium remains still challenging to remove radically or subtotally, or even, you say gross total excision, and they come back with the recurrence for some reason. If you feel you're not left anything post-operative scan, and it is difficult to manage. And I agree with Takasi. We have found radiation is not very helpful in this kind of cases, especially if there is a calcified lesion and if it is left behind, and if you try to radiate, it doesn't work and they still recur. And it becomes more difficult to remove the tumor after radiation than without radiation because of the synechia which we develop. And the craniopharyngioma still is a very, very challenging, in my experience found. And the recurrence rate is significantly more, almost in most of the series is around 20% we are seeing. And yeah, only good thing is that this endoscopic approach gives you a better preservation of vision than the transcranial approach. That, yes, definitely it is there. And whenever you try to dissect out this capsule from the surrounding structures where this capsule is adherent, post-operatively patient has some issues in form of diabetes insipidus or some kind of a visual disturbances also I've seen. And this is what I say feel at times we have to leave the capsule behind.
Yeah, no, I think there is no single recipe for every case. I think that that every case often we plan, and what we see during the surgery is what's going to guide us. So I think that with the vision, I think the key point is, of course, the optic nerve, and then in chiasm, any recurrences, because of previous surgery or radiation, you got to be very careful with the plane, because even if you keep everything intact, if you devascularize the nerve, you're going to have a new deficit, and that capsule and the arachnoid and the vessels can be one after initial treatment. And as you mentioned, like things like diabetes insipidus, I mean, with extensive resection, they're going to happen for sure. But the one thing that I found different comparing like the endoscopic and the transcranial, and I think that's really the big difference in terms of patient recovery, is the whole issue of hypothalamic thunderstorm that we don't have as much in endoscopic as we used to have with transcranial. And I believe that probably is just that better visualization with the planes that we can have with endoscopic that has helped. Otherwise, every single case is different, and we got to make a lot of decisions even during the surgery.
Hey, Dr. Almeida, listen,
good.
thank you very much. We could go on and on. This is such an interactive session. I really thank you. And I put your email in the chat. If anybody has more questions to ask, just write Dr. Almeida. And
Thank you very much, everyone. Appreciate the opportunity and looking forward to talking with you soon. Thank you.
Thank you, Dr. Almeida. Yeah, I think
Thank you, Dr. Almeida.
craniomeningeoma is a very interesting topic, and we still have a lot of problems need to talk, but maybe next time. So thank you again. And then please welcome the next speaker, Dr. Junguo Cao from Zhejiang University, Hangzhou, China. And he will talk about the evaluation of targeted anti-cancer drugs for the treatment of aggressive meningiomas. Dr. Cao, can you start your talk?
Sorry, wait a moment.
Okay, no problem. Yeah, just share your screen.
On the
Or,
PowerPoint. Where is it? No. Sorry, I don't know why I can't share my.
okay, are you seeing the icon for screen share, share? Do you see that option on your screen? Share?
Yeah.
You had it before, right?
Yeah.
Is there a share option on your screen? You're using a desktop, right?
Yeah. I try to share my desktop.
Yeah, okay. When you click on share, what happens?
It's totally blank.
You may need to download the latest version of Zoom. We can wait. Let me
Where is it?
I'm gonna put the address in the hold on.
What's the problem? No.
Okay, did you see the address I put in the chat to download the latest version of Zoom?
Okay.
You see the address?
So yeah.
Okay. www.zoom.us/download.
Trying to download it. Yeah.
It just takes a minute, less than a minute to download it. And you may have to reboot so the changes will take effect.
This one. Sorry.
Any progress? Dr. Kao,
We just download the app. You see?
are you downloading it?
Yeah. I can't share the screen maybe because of the safety problem.
No, have you downloaded the new version of Zoom?
So
You have to download.
yeah. Yes. Where is it?
Wanli, maybe if you explain it.
The connection very bad. No, there's just only 2 speakers today.
曹大夫，您是不是用的电脑还是手机？是他那
我用
个
的电脑，我可以把我的 PPT，比如说分享给谁，然后帮我共享一下。
这个可能有点麻烦，因为
啊，
你是点了共享键没反应吗？
对对，它全是白的。
不是，那他这个这样是说你最好重新下载一个
对，我还在下
新的
这个
Zoom。
会
没关系，没关系，他反正这个网上的会，他们也都等一会儿就没关系。这个不像咱们自己。
我也不知道为什么，开始测试的时候还好的。
或者你就重启一下電腦，反正它这个 Zoom 是因为咱们国内用腾讯会议，但是国外它腾讯会议看不了，它只能用 Zoom。没关系。John, I just told Dr. Cao ask he restart computer or download the Zoom.
Okay.
But it might take a few minutes, so maybe we just
okay.
have
We
a
wait.
break.
We wait. Yeah, we wait.
Like 3 to 5 minutes. Yeah.
Yeah, it's okay. We'll wait.
Okay.
Tell him don't worry. He's got to make sure he turns off the computer completely. The problem is, go ahead.
He said before the meeting, when he tried to share the screen, that's okay. But now, when he touched the button, the share screen button, the screen became white.
Oh, there we go. Okay, he's got it.
Yeah,
now.
that's okay.
It's working. It's working.
Mm-hmm.
Now it's just beautiful. Beautiful. Perfect. Okay. You got it.
Okay. Good. Excellent.
Oop.
You can just start.
Try to hide the camera.
Hey, you went back to the you're not on the full screen now.
Okay.
Yeah. Okay, perfect.
Okay.
Perfect.
Okay, thanks for your waiting. And today, I don't, sorry, I can't change. Maybe I can use this. Okay. Yeah, my talk is about the evaluation of targeted anti-cancer drugs for the treatment of aggressive meningioma. And firstly, I would like to show you some background information about the meningioma. Meningiomas are the most common primary central nervous system tumors originating from arachnoid capsules. According to the WHO classification, we know that around 78 to 81% of meningioma are grade 1, and 15 to 20% of them are grade 2. And only 1 to 4% of meningioma are malignant meningioma, also the grade 3 meningioma. About the 10-year survival rate of patients with meningioma, the grade 1 meningioma is around 77%, and grade 2 meningioma is around 71%. However, about the malignant meningioma is only 23%. And nowadays, the primary treatment options for meningioma are observation, surgery, radiotherapy, but there is no effective chemotherapy or targeted therapy available for meningioma. But there are many key genetic and epigenetic alterations have been identified in meningiomas, which may lead to the development of targeted therapies for meningioma. The objectives of my project is to identify effective drugs for the treatment of meningioma by high-throughput drug screening using the newly established drug library in vitro. And secondly, we validated the potentially effective drugs functionally and mechanistically in cell lines, patient-derived tumor organoids, and orthotopic xenograft mouse models. After talking about the background information and the objective of my project, this slide shows you the overview of this project. Firstly, based on 4 meningioma cell lines, we tested each drug from the drug library. Yeah, we divided the high-throughput drug screening into 2 steps. In the first step, we only used a single dose of each drug from the drug library. We selected the top drugs for the secondary screening. In the second step, we used different doses of each drug and then tried to establish the dose response curve. And then we selected the top 9 drugs according to the IC50 or the values or the AUC values for each drug. And we further validate the effect of these top 9 drugs in vitro, ex vivo, and in vivo. Here, this slide, I would like to show you how did we establish the drug library. From a paper just published in our lab, we know that there are over 20,000 of genes expressed in malignant meningioma. And for all of these genes, we identified that 442 genes had inhibitors available. And then from these genes, we try to find how many inhibitors for each gene have. And then from these, all of these inhibitors, we try to find how many inhibitors will investigate in clinical trials. Next, we excluded the drugs that have been previously studied in our lab. Next, we selected at most 3 drugs per gene, considering the number and phases of the clinical trials, because for some genes, they have many inhibitors. We don't want to investigate all of these inhibitors targeting 1 gene. So finally, we have 107 inhibitors for 46 genes left. This figure shows you the distribution of the drug classes of this drug library we just established. From this figure, we could see that we have 6 FGFR inhibitors, 6 HDAC inhibitors, and so on. So let's have a look at the first part of this project, high-throughput drug screening. In the primary drug screening, we selected 2 from these 4 meningioma cell lines, I mean the NCH93 and IMLE. Both meningioma cell lines are malignant meningioma cell lines. And for each drug of this drug library, we only use 2.5 micromolar. And after 48 hours treatment, serotype glue was used to measure the viability of these meningioma cells. And then the figure B shows you the results from the primary drug screening. X-axis is the viability of the NCH93 cell lines, and the Y-axis is the viability of the Bimonthly cell lines. These drugs in this green part, which means that these drugs can inhibit the viability of one of these two meningioma cell lines. And then we selected all these 33 drugs for further validation. In the secondary screening, we used 4 meningioma cell lines, NCH93, Bimonthly, KT21, and Bimonthly. For each drug, we set 6 doses from 0.1 to 10,000 nanomolar. And after 48 hours incubation, serotype glue was also used to measure the viability. And then based on this result, we established the dose response curve of each drug in these 4 meningioma cell lines. And after that, we could calculate the IC50 values, the AUC, which means the area under the curve, and the Emax is the effect when we use the maximum concentration. All of these values are related to the effect of this drug in meningioma cell lines. And the figure C shows you the result from the secondary screening. X-axis is the Z transform of the AUC value. The Y-axis is the Z Emax. So we could see that these 9 drugs in the green area are the drugs which have both Z AUC value and Z Emax value lower than 0, which means that these 9 drugs are very effective in the inhibitory of the meningioma cells. We also validate the IC50 values of these drugs by crystal violet assay. Here, this table shows you the phases of clinical trials, the primary targets, and the IC50 values of these top 9 inhibitors in 4 meningioma cell lines. Next, we try to validate if these top 9 inhibitors can show inhibitory effect in meningioma cell lines. We performed the BRDO proliferation assay. The meningioma cells were treated with 5 times IC50 values of these top 9 drugs. After 24, 48, and 72 hours, BRDO proliferation was performed. And from this result, we could see that all of these top 9 inhibitors can reduce the proliferation of meningioma cells. We also continue to validate if these drugs can induce cell cycle arrest, apoptosis, and inhibit the migration of meningioma cells. Yes, from this result, we could see that exactly all of these 9 drugs can induce cell cycle arrest, apoptosis of meningioma cells, and most of the top 9 drugs can also inhibit the migration of meningioma cells. After the validation of these top 9 drugs in vitro, we try to establish the patient-derived meningioma organoids. This flowchart shows you how did we establish the patient-derived meningioma organoids. Firstly, the fresh meningioma tissues was minced into small pieces, and then after enzymatic dissociation, the primary single cells were incubated with a special particle nanoshuttle, and then after overnight incubation, 25,000 of cells were seated in each wear of the plate, and after 3 days incubation, the organoids formed, and then we treat the organoids by different doses of these top 9 drugs. And then serotype glue 3-dimensional was used to measure the viability of these organoids. Here, this slide shows you the characterization of the meningioma organoids. Figure A shows you the bright field images of different sizes of the organoid at different time points. The figure B is the life and death staining of these organoids. You could see that the organoids can keep very good viability. And the figure C shows you the actual staining of these organoids. And these organoids show very dense structure similar to the parental meningioma tissue. And then the figure D and figure E show you the viability and the size of the organoids with time. And although at the beginning 2 or 3 days, the viability of these organoids continue to decrease, but they can keep very stable in around 2 weeks. And then we also perform the IF staining of these organoids by EMA, fibronectin, and CD68. All of these experiments show you that our organoids can also keep the structure and the microenvironment of these meningioma tissues. And figure G and figure H, we perform the RNA and DNA sequencing of both meningioma organoids and the parental tissue. We could see that these organoids can recapitulate the transcriptome and the genetic profiles of the parental tumors. And we continue to perform the drug screening to validate the effect of these top 9 inhibitors in around 60 cases of patient-derived meningioma organoids. And the figure A shows you the AUC of each drug in each case of all of these organoids. You could see that the OTSSP and panabinostat are always the top effective drugs among these 9 inhibitors. And figure B shows you the AUC value of these top 9 inhibitors, and figure C shows you the FC 50 values. So just like I mentioned, the OTSP and panabinostat are always the top 2 effective drugs. So we also performed the life and death staining for these 2 drugs treated organoids. The first 2 organoids were treated by DMSO as a negative control, and another 4 organoids were treated by 1 micromolar OTSP and the panabinostat. After 48 hours treatment, we performed the life and death staining. The green means that the organoids show very good viability, and the red part, which means that the dead cells. So you could see that these 2 drugs can really kill the organoids. And we also try to study if this, because OTSP actually is a kind of MEK inhibitor, so we want to know if the OTSP can really inhibit the MEK and then try to decrease the viability of the meningioma organoids or meningioma cells. So we also selected another 2 MEK inhibitors, J and J, and MEK8A. So we treated around 5 cases of meningioma organoids by these 3 MEK inhibitors. However, from the results we could see, the figure A show you only the OTSP show very effective drug results. However, another 2 drugs almost no effect. So about why, what's the reason? So we perform the siRNA mediated MEK knockdown. So from this result, we could see that after knocking down the gene, the MEK gene, the viability of the organoids can very similar to the DMSO control, which means that OTSP maybe does not transduce its anti-meningioma effect through the inhibition of MEK. And then for the panabinostat, because it's a kind of pan-HDAC inhibitor, so we also selected other 4 HDAC inhibitors, and then we compare the effect of these 5 HDAC inhibitors. And from these results, we found that the panabinostat show very similar results to romidepsin. Actually, it's a kind of a highly selective HDAC1 and HDAC2 inhibitor. So we want to know if the panabinostat also have the very similar mechanism to romidepsin. They maybe panabinostat maybe inhibit the HDAC1 or HDAC2 to perform its effect. So firstly, we try to perform the SI. So we also use the siRNA to knock down the HDAC1 or HDAC2. Yeah, we found that this result, the figure A shows you the result after knocking down HDAC1, the single knockdown HDAC1 or HDAC2. There is almost no effect for the viability of the meningioma cells. However, if we double knock down both HDAC1 and HDAC2, it really decreases the viability of the meningioma cells. So yeah, we have this maybe the panabinostat performing its effect by dual depletion of HDAC1 and HDAC2. And finally, we performed the animal experiment. We established the orthotopic meningioma mouse model. After 1 week, we used the panabinostat and OTSSP to treat the mouse model, and then 5 times per week, in total 3 weeks. And then we observed the survival of all of these mouse models, and we record the survival times of each mouse. The figure B shows you the Kaplan-Meier survival curve of each group. From the result, we could see that the panabinostat and OTSP can really significantly prolong the overall survival time of this mouse. And the figure C, we performed the IHC staining for the Ki67, which is a marker for the proliferation. So we could see after treating by the panabinostat and OTSP, the expression level of the Ki67 decreased significantly. And the figure D show you the some images of the IHC staining for each group. So that's all about this, all results about this project. In conclusion, we after performing 2 steps of high super drug screening from this drug library, including 107 inhibitors, we identified top 9 inhibitors which demonstrated potent efficacy against meningioma in vitro. And secondly, another patient-derived meningioma organoid model was established successfully, which maintained the genetic and histopathological features of the primary tumor, which also can be generated in large quantities and standardized in size. Certainly, the panabinostat and OTSP demonstrated very huge anti-meningioma effects ex vivo, and these 2 drugs, a mechanism of these 2 drugs, panabinostat may be mediated its effect through the dual inhibition of HDAC1 and HDAC2, and the effect of the OTSP may be due to off-target effect. And finally, both 2 drugs can prolong the survival of tumor-bearing mice, indicating a potential role for the panabinostat and OTSP in the management of aggressive meningiomas. Thank you. That's all about my project. Thank you. Open to your question.
Okay, thank you. Thank you, Dr. Cao. Yeah.
Thank you.
Actually, I want to know, do you have a plan to start a clinical trial for the patients with this?
Not
drug?
yet. Yeah. Also, panabinostat is immune-approved drugs for some T-cell lymphoma like this, but it's always many tumors show resistance to panabinostat, and from the animal experiment, we also could see the side effect of the HDAC inhibitors. So yeah, maybe there is still a long way for us to start the clinical trial of these drugs. And for the OTSSP, yeah, at least from our experiment, we could see maybe it shows its inhibitory effect because of the off-target effect. So about the detailed mechanism, yeah, we still have to study, yeah, in the future.
Okay, thank you. Are there any questions? Mm.
Takashi, you have any comments, questions?
Yeah. Thank you. I'm Dr. Gong from Tokyo, Japan, Showa University. Thank you for nice presentation. As for aggressive meningiomas, so still difficult, only not only removed by surgery, some are very aggressive, invasive one. So the molecular targeted therapy is also important. So you kind of promising drug development will be expected. So are there any difference between your drug concepts to save, to improve, to prohibit invasion, tumor invasion or tumor aggressiveness? So are there any ideas or some kinds of drug possibilities of to inhibit invasion, those kinds of drugs, or some kinds of anti-immunology treatment or something?
So you mean if this drug can inhibit the invasive of the meningioma? Yeah, from
Yes,
the
that's
in vitro experiment, we could see that these drugs can also inhibit the migration of meningioma cells. But for the invasive, yeah, it's very hard to check. Maybe yeah, from the animal experiment, if we resect the tumor or the whole brain, we could see that if the tumor can invade or show invasive behavior, and then if we compare the experiment group to the control, yeah, but unfortunately we didn't perform such kind of experiment. Maybe in the future we could see if this drug, I mean, the HDAC inhibitor can inhibit the invasive behavior of the aggressive meningioma. Very good
okay.
comment. Thank you. Yeah.
Thank you. So we expect a future study of your experiment. Thank you.
Okay. Thank you.
You got your next work cut out for you. Okay, any more comments, questions before we close? I want to thank you for an excellent presentation. That's two great presentations today. We had a good day, Takashi.
Yeah.
So, okay, I'd like to thank Juan Lee for helping us here, and of course the two speakers and the supporting cast of Juan Lee and Ramakan, Tanzania, also Harshad Parekh from India. And so we'll see you in 2 weeks, everybody. Just hang around if you'd like.